the shoulder dislocation in the elderly population is little different when compared to the younger individuals. So we'll just go through like how it makes a difference. So there is an increasing incidence of these dislocations in the elderly because of their very poor muscular stability, and also there is a frequent falls. They have seen that there is an increasing incidence of dislocation, particularly in the over the 80 and 90 years of age group. They have seen that women is more common than men. So, and the recurrence rate is quite variable in the literature. It varied from 0 to 31%. And most of these shoulder dislocation are either associated with kind of tuberosity fractures or comminuted fractures. And there is also some incidence of neurovascular injuries, and cuff tear is the most common association. So as Vivek sir told, an elderly individual who is not able to lift his arm following a shoulder dislocation, it is very likely that he is having a cuff tear. So there is an entity called pseudo paralysis, where there is a massive cuff tear and the patient is unable to lift his arm. So this is the various literatures which have shown that there is a incidence from 0 to 31% of recurrence rate following in over the age of 40 years. So pathophysiology, as we know that there is, as the age advances, there is loss of elasticity in the capsulolabral complex, as well as we know that there is a degenerative cuff, which is torn in most of these elderly individuals. So there are two mechanisms which have been described. It is called as anterior mechanism, which leads to the lesion of the anterior labral complex, and with a sudden eccentric load on the posterior cuff, it results in a partial or total rupture of the pre-existing degenerated cuff. So Craig demonstrated that in the posterior mechanism, where the limb is in complete abduction, flexion, and external rotation, it leads impact of the posterior cuff on the glenoid rim and results in its rupture. So this paper by Rapris et al. Have shown that the degree of rotator cuff involvement on the coronal plane does not significantly affect the shoulder outcome, but the tear in the sagittal plane does influence the outcome. So this paper by Sang-Shin Shin has very nicely given an algorithm how to approach in these elderly individuals following a shoulder dislocation. So when primary dislocation, you do a gentle manipulation, close reduction, and then you immobilize by in a sling for a couple of weeks, and then reassess. If the patient is asymptomatic, you can treat them conservatively. If the patient have the symptoms, inability to lift the arm or pain, and then you go for the investigations, whatever is available like ultrasound or MRI, and see which is the pathological structure. Either it is the rotator cuff or the capsulolabral lesion. So whenever there is a massive cuff tear, it is advised that you do cuff repair alone. But in case of a small partial or a small cuff tear, there is always an associated capsulolabral lesion. So here is the situation where you may have to deal both the structures, both the pathologies. So early detection of these pathology and timely intervention gives an satisfactory outcome. So this paper in JCS have again confirmed that the rotator cuff is the main pathological structure, and early surgical intervention prevents the morbidity. And over the age of 50 years, these patients have a massive cuff tear, and early intervention again has an excellent outcome. This is a very big study by Gumina et al., who have studied 545 patients of shoulder dislocation, where they have seen 20% to be over the age of 60 years. And axillary nerve injury was seen in 9%, and they recovered in due course. The recurrence rate was around 22%. So around 60% patient had cuff tear. So they suggested both cuff and stabilizing procedures to be done. So there is incidence of axillary nerve and suprascapular nerve sometimes can be injured. The vascular injury, that is the axillary artery, is the most dreaded complication, and it is an infrequent complication which is seen in the elderly individuals because of the associated atherosclerosis of the vessels, and they present with diminished pulse and protruding axillary hematoma. So it is very important that we don't miss these very rare injuries, which is a devastating injury if you don't get it in right time. So we'll just see certain again, a 62-year-old gentleman who had a fall on his outstretched hand, and he dislocated with a back in place. So we continued to do a conservative management for this patient, and he had a good satisfactory outcome. Again, this individual over the age of 56 years had a similar anterior fracture dislocation. Here the GT fragment was quite big and it displaced. So we decided to do a fixation with the Philos plate, and this patient had a satisfactory outcome. This is a more complex fracture dislocation where you can see that it was a complex 4-part fracture. So we again went in, we did a good suture bridge plating. We took a couple of sutures in the cuff anteriorly and posteriorly, and this patient had an excellent outcome in spite of this complex injury. So here we were able to achieve a reasonable outcome. So we were able to bring the cuff with the GT fragments onto the plate, and this patient had a satisfactory healing. This is again a road traffic accident. 62-year-old male also had a head injury. So he sustained a posterior dislocation again with the LT fracture. So we did a close reduction, and then later on we fixed his lesser tuberosity using, because it was still displaced and it was an unstable, so we decided to fix it, and this patient did well. So now coming to this individual who was a pylon rider who fell on from the bike and landed on both of his outstretched hand. So he sustained distal and radius fracture on the right side and dislocation on the left side, right side, and radius on the left side. So we did a close reduction and pinning of his radius fracture. So this patient we treated conservatively, and when he came back after 2 weeks, he was like 1 week, he was absolutely was not able to lift his arm, and so we suspected pan cuff tear. So we advised an MRI. So the MRI confirmed that he had a pan cuff tear. So we decided him to take up him for the procedure and repair the cuff. So we found that the labrum was intact here, and there was a huge cuff tear, both subscap and supraspinatus. So we did a mini open double row cuff repair for this individual gentleman, and he was able to, at the 3 weeks follow-up, he was able to lift his arm, which he was not able to do in the pre-op state. So this is another similar case. He's our pediatrician's father. So I just could not have his previous X-rays and MRIs. Yeah, it is his outcome. We did a pan cuff repair for him. So this is another 65-year-old gentleman who again had a road traffic accident, head injury, and again he presented to us after 3 weeks. Again, inability to move his arm. So on evaluation, this was the CT, like he had a bony bank cut. So we got an MRI done. So MRI showed that there was an associated full thickness cuff tear. So we decided to do an arthroscopic assisted fixation of the bony bank cut, glenoid, and also we did a mini open cuff repair for this individual gentleman, and he had an excellent outcome. He has never again dislocated after this procedure. This lady, 60-year-old lady, in fact, before this injury, she presented to our outpatient. She had a small cuff tear for which we suggested a cuff repair for her, but she presented with this dislocation. So we did a close reduction in the ER and then asked her to review with a fresh MRI after 1 week. Since she already had a cuff repair, cuff tear, pre-existing cuff tear. So the fresh MRI showed that there was a full thickness cuff tear as well as a hill sac and also anterior capsulolabral tear. So we took her for the procedure, and we could see that her entire anterior labrum and anterior capsule was torn. So we did a Bankart repair for her. And also we did a mini open double row, and this lady also had an excellent outcome. So in our series, we had 20 cases of elderly dislocators. So we are from 50 to 80 years of age group. So we did close reduction alone in 7 cases. We did cuff repair in 3 patients and cuff repair with stabilization in 4 patients, and fracture fixation was done in 6 patients. So the controversy exists as to whether either the cuff repair alone is sufficient or to do a stabilizing procedure or the labral repair. So Itoi and Tabata et al. Have shown that cuff repair alone is sufficient, but Gumina et al., the counter argued that anterior stabilizing procedure definitely was needed in certain cases and it improved the clinical outcome. Shin et al. Gave much better suggestion. So they told whenever there is a large massive cuff tear, it is sufficient to do a cuff repair. But in case converse, when there is a small cuff tear or a medium-sized cuff tear with capsulolabral complex tear, so it is better to address both of these pathologies. So the message was very clear. So shoulder dislocation in elderly is generally more common than we believe, and also the redislocation rate is up to 31%. 60% have a cuff tear. So early identification and addressing this pathology has a very satisfactory outcome. So if you miss the anterior capsulolabral pathology in small cuff tears, the patient present to you with recurrent pathologies. So thank you, and all.